coffee now, post-meal. Yeah, one of the things I love about IATA and this community is all the different backgrounds and areas of expertise. And the morning was very high level for someone like me, a clinician, funding and policy, and it's not my day to day. And so this afternoon we're switching gears more into the clinical space, which is my thing, so I'm very excited to talk about diabetes and pregnancy in humanitarian settings. So this is a first foray into this conversation for our group, I think. And I will hand it over to Philippa Boole, who will be moderating the session. She is the NCD advisor and head of the chronic conditions team at MSF. She also has been co-leading the service delivery working stream at IATA with me. And she was just appointed to be the deputy medical director of MSF Switzerland starting in November. So that's a big deal. We're really excited for her. So over to you, Philippa.
Hello. Great. Thank you, Sylvia. Good afternoon, everyone. I'm really happy, actually, for this to be one of my last key duties as NCD advisor, is moderating this session. And as Sylvia said, we're going to really bring this down to the ground and what are the challenges on the ground. And so this will be one of two sessions, this symposium, where we're really looking at what are the kind of somehow neglected or under-addressed issues relating to diabetes in humanitarian settings. And so, we know that pre-existing type 1 or type 2 diabetes during pregnancy or that gestational diabetes come with increased risks of maternal and neonatal morbidity and mortality. We know that these risks are amplified in humanitarian and fragile settings due to lack of resources, untrained staff, fragmented care, and so on. But we also know that there have been some efforts to look at this. So really today we want to take you through a bit of a journey on that. And really then at the end want to get a bit your input. So we're going to look at what are the needs around diabetes and pregnancy, what do we mean by diabetes and pregnancy, and what are the implications, why do we need to address this topic, what is happening at the moment, what are the opportunities, but what are the challenges that are being seen, and then have a bit of a discussion together on, with those opportunities, what is the way forward? And I think this is something, IATA is really interested to look into. It's come up many times over the last years, but there's not been a concerted effort. So we hope that this will kind of be the start of a journey to see how this can be better addressed. And when we come to the audience, I really encourage your not just your questions, but also your reflections, your ideas, so we can think about, how can we move this topic forward, and including the kind of research priorities, which is one of the things we really want to look at in this symposium as well. So we have a great panel who's I'm not going to say very much because I'm going to leave it to the expert panel. So I'll introduce the panel and then we'll start. So we're first going to have Chloe Zira, who is the chief of the Division of Maternal Fetal Medicine at Beth Israel Deaconess Medical Center and an associate professor of obstetrics, gynecology and reproductive biology at Harvard Medical School. She's a recognized expert in the care for people with diabetes and pregnancy and an advocate for comprehensive and equitable reproductive health care. And Chloe's going to set the scene for us, so we're all on the same page in terms of understanding diabetes in pregnancy and its implications. And then we're really going to center this conversation. I think Aurea really set us up for this really well in the last session. We're going to center it on what does it mean to live as a woman with diabetes in a humanitarian setting or in general during pregnancy. And so we have Serene Farhat, who's a global diabetes advocate and person living with type 1 diabetes in Lebanon. She's founded the NGO Positive on Glucose, and she's currently doing a PhD focusing on ethical access to insulin and community-led NCD advocacy. And she's very generously agreed to share with us her experience so that we can, of living with diabetes during pregnancy. So we can really hold that in our minds as we move through the discussion. Doris Chu from WHO is a medical officer at the Maternal Perinatal Health Team of the Department of Sexual and Reproductive Health, why does everyone have such long titles? So she's responsible for the overall coordination of maternal and perinatal health norms and standards. And she's going to share with us the work that WHO has been doing to develop guidance on this, and hopefully also share some of the challenges around developing that guidance, and perhaps some of the gaps that will, that related to humanitarian settings, also to help us understand where do we need to put some work into understanding this better. Reham Jafel, working with UNRWA since 2010, has 15 years of experience in public health and a strong focus on primary healthcare services, and she's currently the Chief of Health Protection and Promotion at UNRWA headquarters. So she's going to share with us the extensive UNRWA experience on implementing NCD care and maternal health care, and what they've been thinking around diabetes and pregnancy and some of the more recent challenges they've been facing. And lastly, but not least, Nelly Stederini is a French midwife with a public health diploma who has extensive field experience in humanitarian settings, and for over a decade has been working with us in MSF Switzerland as the SRH and sexual violence advisor. And she's going to share with us what MSF has been developing and trying to do, but also a lot of the very real challenges on the ground. So that's enough from me. I'm sorry it was so long. Let's move on to Chloe, just to share with us about what are we talking about today. Thanks, Chloe.
Yep, thank you. And thank you to IATA for inviting me here. You might wonder why a obstetrician from the Ivory Tower in Boston is here, but my clinical practice really is focused on people with type 1 and type 2 diabetes, a little bit of GDM thrown in there. And I have taken kind of a left turn from clinical research, how I started my career, into advocacy. So I do a lot of domestic advocacy work, and a lot of what has been said today really resonates, and I'm really looking forward to our conversation. So thank you. So just to level set a few definitions. We call diabetes in pregnancy that is pre-existing, referring to people with known type 1 and type 2 diabetes. There is also a category of diabetes that is first diagnosed in pregnancy that probably is pre-existing, and this is a really important segment of the population where I practice because people don't necessarily have access to any sort of health care before pregnancy. They may not have had any sort of ongoing primary care or screening. And then there's gestational diabetes, which officially is hyperglycemia diagnosed during pregnancy, usually second or third trimester, that is not clearly one of those other two things, overt diabetes. And I just put this long, complex table up here to say that we have been fighting over the diagnostic criteria for gestational diabetes my entire career. So for the 20 years that I've been doing this, it has not been decided on. Reflecting on the panel from earlier, I think much of that maybe because people with lived experience were not necessarily included in the discussion about what the right sort of cutoffs are. But the ones that I sort of left dark, Carpenter-Kustan is the US criteria. We use a two-step screening strategy typically, not every center in the US, but many, I'd say the majority, with a glucose tolerance test, which if abnormal prompts a 3-hour bigger glucose tolerance test, versus a 2-hour glucose tolerance test. All of these use different doses of glucose, but I think the experience of people taking the test is many blood draws and a large bolus of a very nasty tasting orange drink. GDM is very common depending on how you define it. So getting the actual prevalence depends on how you define it, but this is recent estimates from the IDF, where you can see that in many places, more than 20% of the population has been diagnosed with gestational diabetes. The IDF estimates for the number of people affected by diabetes during pregnancy is approximately 1 in 5 worldwide. We don't have comprehensive data for much of the world, but in the places where we do, you can see that most countries have at least 10% of their population affected. Pre-existing diabetes prevalence, so pre-existing diabetes is much less common, ranges from about 0.5% to 2.5%. The big variance is due in part to variations in the proportion of people diagnosed with type 2 diabetes in a given area. as well as type 1 is pretty, sorry, this is where the jet lag kicks in. So if I start to sound incoherent, told you it was going to happen. Just lose a train of thought midway through. At any rate, diabetes, much less common when it's pre-existing, but it's there. Type 2 diabetes is going up rapidly. This is just a chart illustrating the change in prevalence, which has gone up, roughly doubled in the last 20 years. That is consistent with IDF data. This is US data, but very similar. And getting back to get that definition of what gestational diabetes is, one of the challenges with diagnosing gestational diabetes is that there is a very linear relationship between maternal glucose tolerance and fetal outcomes and maternal outcomes in pregnancy. So basically anywhere where folks have tried to draw a line in the sand that this matters or this doesn't matter, you leave some people behind and you find some others, right? So with any screening test, there's going to be a decision about who do you want to screen and what kinds of resources do you want to invest in this problem. And I think that's something to keep in mind as we move forward. But even mild gestational diabetes has a fairly significant impact. So the most significant maternal impact in terms of things that can actually be potentially fatal is the association of gestational diabetes or any kind of diabetes with hypertension and hypertensive disorders of pregnancy. Very common in people with diabetes. Cesarean delivery, obviously more common as well, in part due to macrosomia. So fetuses at risk for being big, particularly in people with type 1 diabetes. So the risk for birth trauma is higher, the risk for jaundice, hypoglycemia, things that prompt neonatal care. In terms of the impact of pre-existing diabetes, the risk for perinatal mortality is actually fairly significantly increased. This risk similarly is linearly associated with how you come into pregnancy. So people with well-controlled diabetes in pregnancy, and I tell my patients a lot of the time now, we don't have any data actually on outcomes in the post-hybrid closed loop era. You know, even in the post-CGM widely used era, we don't have good outcome data. So for people that I primarily take care of who have kind of access to advanced technology, the outcomes are probably much better than this. For people with type 2 diabetes living in the US, they're actually quite bad. And we know that there is some correlation with social determinants of health, but it's partly also because we have not invested the same amount of time and energy in the care for women with type 2 diabetes. So the recommended care for type 1 diabetes, I should say one thing, sort of the physiology of pregnancy and what that does to diabetes. So I showed you how diabetes affects pregnancy. Pregnancy also markedly affects diabetes. So pregnancy is a state of sort of metabolic syndrome. Basically, everybody's insulin resistance dramatically increases as their placenta grows. And I tell people as it gets harder and harder to manage your diabetes, this is good because it means your placenta works, and we're happy about that. But particularly for people with type 1 diabetes, I think one of the challenges is that they are doubling or tripling the amount of insulin they need over the course of a pregnancy. And it's so dynamic and so hard to find a steady state that it can be like a full-time job to manage their diabetes. So the current recommendations from the American Diabetes Association and from I was part of a recent guideline development panel with the European, a coalition of European groups and US groups. CGM is definitely recommended. We also are recommending use of a hybrid closed loop system. Different options for delivery of insulin, but insulin is really important. Things that prevent hypertensive complications or at least reduce the risk of hypertensive complications are also important, and that includes low-dose aspirin and controlling high blood pressure, which is a big paradigm shift even in the US to sort of aggressively control maternal blood pressure prior to the development of a hypertensive disorder. And then I sort of made this bullet, obstetric monitoring and risk-based delivery planning. So what that looks like is very different, even across centers in the same city in the US. We can't agree on what the best way to prevent stillbirth, to prevent traumatic delivery, to prevent NICU admission. Like balancing all of those neonatal and fetal risks is challenging, and we have kind of flawed tools. We basically have non-stress tests and ultrasounds, which is it. And so when the right time to deliver a baby, which way to deliver a baby, these are all questions that we don't agree on, and how to monitor a pregnancy. But they are really important. So that's sort of a catch-all for whatever the local standard is. For type 2 diabetes, very similar, I would say. CGM, I put preferred question mark. We don't have any data demonstrating that CGMs are definitively better than self-monitoring of blood glucose for people with type 2 diabetes. I can tell you clinically, most people prefer a CGM to the 4 to 6 finger sticks a day option. And as they have become more widely available to people without type 1 diabetes, they have become much more standard, even for gestational diabetes. For gestational diabetes, one of the ongoing controversies is what's the optimal medication for treatment. So depending on how you define and diagnose gestational diabetes, somewhere around 90% or less, the more stringent your criteria, the more people will be controlled just with diet. So the more people you diagnose, the more people are able to manage their diabetes with diet alone. There are sort of two different patterns of gestational diabetes. One with fasting hyperglycemia dominating, which is kind of the baseline insulin resistant pattern. And then the other where they have really significant postprandial hyperglycemia. And so for those folks, diet modification often works really well. For people with baseline insulin resistance, that is their method of diagnosis, it's really hard to control them without medication. Right now, insulin is what is in the US guidelines for the preferred agent. Metformin crosses the placenta, and I would say it's an ongoing controversy. We know metformin has some effect on pregnancy outcomes, but there is at least one ongoing large randomized controlled trial. This particular trial is novel in that it includes patients and patient advocates and some qualitative outcomes and some a focus really on what people's experience of using metformin versus insulin is. And I think, again, clinically, most of us feel like metformin is highly acceptable and insulin is not always. So certainly something that we're trying to establish the safety and efficacy of still. The other piece of recommended care for gestational diabetes, and this is maybe where I will highlight some of the challenges in the US that are potentially going to affect this community. Postpartum screening for overt diabetes and prediabetes, and ongoing sort of screening and diabetes prevention. So I'll come back to that in a second. But I'll just say that gestational diabetes indicates that people are at very high risk for progression to type 2 diabetes. So about 50% of people with gestational diabetes will progress to having type 2 diabetes within 10 years. It's about a 10-fold increased risk as opposed to a pregnancy where somebody does not have GDM. And it is a fairly old cost-effectiveness study now. So this was 2011 US dollars, but this was published right after the IAD-PSG criteria, which is the criteria that I believe the WHO also endorsed. When those criteria came out, this cost analysis suggested, you can see the numbers, that screening would prevent 85 cases of shoulder dystocia, 262 cases of preeclampsia, and nearly 700 cases of future diabetes. So by far and away, the thing that drove what was cost effective was, does post-delivery care actually prevent diabetes? So if we use GDM as sort of a metabolic stress test and a marker for future disease and a way to get people risk stratified into disease prevention, then all of this screening and testing is worthwhile. If we don't, which I can tell you in the US, we screen 20 to 30% of people with GDM within the first year. So we are not doing well even with the screening, let alone the treatment and care delivery to prevent the diabetes. So when we don't, we are definitely not doing a cost-effective intervention. Now, whether that intervention is good for patients is a different story, but it's certainly not cost-effective. And I just pulled out this figure from the recent guidelines that we put together, the Endocrine Society and European Society for Endocrinology guidelines. And it sort of highlights the continuum of reproductive lifespan for people with pre-existing diabetes. So We know that preconception care is probably the most effective thing we can do to prevent perinatal mortality and pregnancy complications. As I mentioned, how people enter pregnancy is pretty much how they're going to do. So if people come into pregnancy well controlled, it really can improve their outcomes, and getting those people to health care prior to pregnancy is extraordinarily important. Prenatal care matters for sure. I think hearing some of the priorities from this morning, you need insulin, and you need a lot of insulin. I mean, I have patients with type 2 diabetes who are on 200, 300 units of insulin per day. That's what they require to control their blood pressure or their blood sugar. And so it is a lot of insulin access that would be really important for prenatal care. And then I think, you know, when we think about the delivery planning, that was another piece that we looked at. Delivery planning, I think we can argue about what strategy is the best way to plan for a safe delivery, but certainly planning for a safe delivery in some way is an important piece of this care. And finally, that transition to postpartum care, specifically addressing contraception needs and screening for future pregnancy intent, again, to set people up for the healthy next pregnancy. So mostly what I wanted to say is that care delivery for diabetes is incredibly complex. It involves a lot more intervention than is typically, you know, for people with type 2 diabetes, for example. Oral agents essentially don't work at all. They almost all need insulin to control their blood sugars. So it's care intensive. It is dynamic and changing, so frequent visits are needed. It's very resource intensive. And even in highly resourced settings like the one I live in, it is incredibly fragmented. It is incredibly incomplete, and it's a challenge. So I think a lot of opportunity there too, but definitely a challenge.
Where do we go from there? Hello? Yeah, perfect. Great. Thank you so much for that, Chloe. So now we all understand the huge challenges, but also the importance of it. So let's understand what it actually means to live as somebody with diabetes through pregnancy. Thank you, Serene.
Hi, everyone. So when Ayada invited me to talk about diabetes and pregnancy, I immediately said yes. And then I kind of regretted it because it's like this open wound that I'm now going to pour on everyone here in this room. So bear with me when I tell you my story and how I'm here in this room because of it. My name is Serene Farhat. I'm 34 years old. I've been living with diabetes now for more than half of my life. I come from Lebanon. I have a small nonprofit that works on advocacy, building support groups, connecting people with diabetes together. Why and how I became this person? It's because of this story. So in 2019, I was blessed with a baby girl, a pregnancy. And as a diabetic, there were no clear guidelines as how to support a person with type 1 diabetes. So I worked hard to choose a team that could take care of me during pregnancy, and I ended up visiting this married couple. The guy is an endocrinologist, the wife is a gynecologist. One team, right? Perfect. And I thought I was safe. I'm safe. They're not just one team, they're not just one clinic, they're one home, right? I'm safe. And needless to say, it's very out of pocket. It's very expensive to take care of diabetes in Lebanon. And back then, the healthcare system was not even destroyed yet, so it was still very expensive. Monthly visits, tests. And when I was around 7 months pregnant, I started developing these weird symptoms, a bit of swelling, headaches, nausea, tummy ache. And me being me, who likes to read a lot, to research a lot, the first thing that comes on Google is, women with type 1 diabetes have higher risks of preeclampsia. What is preeclampsia? So I go to my gynecologist and I tell her, hey, listen, I read this online and should I be worried? I match the signs and symptoms. And she's like, no, you're obsessed. You Google too much, stop Googling. And then she told my husband and my mother to prevent me from Googling stuff because I'm too anxious and obsessed. Moving forward, New Year's Eve, 2019, making some good desserts to go have a nice time with the family. My baby stops moving. And I know it, because how many moms are here in this room? You know things, right? Yeah, I knew it. She was not there anymore. And so I call my gynecologist, and I tell her, listen, like, my baby's not moving. She's like, oh, you're too anxious again. Go eat some chocolate, lie on your side. She'll move. Maybe it's the placenta. But I knew it. So I call my husband. I tell him, please, can you come and drive me to the hospital? I want to check up on the baby. I wear black because I knew it. And when I go to the hospital, there's no heartbeat. And the first thing my gynecologist tells me is, it's because you're a diabetic. This is very common with women with diabetes. And I literally had an out-of-body experience. It broke my heart and my soul that I killed my baby. As I went into surgery to have a C-section, I hear the anesthesiologist telling the team, she has 3+ protein in her urine. Does she have preeclampsia? And I go to sleep. And I wake up, and like it's in the back of my head, like it was preeclampsia. My gynecologist denies it. My endocrinologist denies it. I get discharged without a baby, without Joya, whose birthday is on 1/1/2020, and I want you to remember that date and honor her memory whenever she crosses your mind, because she is the fuel that keeps me going. And I go to another gynecologist, and I tell him, listen, this happened to me. Can you help me understand what happened? I don't know what happened. And he runs some tests, and he tells me, oh, you have high blood pressure, you have preeclampsia. And this is how the healthcare system failed me. 3 months later, COVID, I have this great idea of creating this online support group for people with diabetes, because I needed to connect with people. We were held hostages in our homes, positive on glucose starts, and I started advocating for speaking up, for access, for women, for diabetes. But the story doesn't end there. COVID, financial crisis in Lebanon, devaluation of the currency, minimum wage hitting $20 per person. A box of Novorapid is $35, by the way. So it was more expensive than minimum wage. Then the Beirut blast explosion. And so lives move on, you know, because we're Lebanese. We're the happiest depressed people in the world, if you've ever heard that. So I get pregnant again. And this time, I'm more aware of what advocacy means. And I tell you, I changed 3 gynecologists during that pregnancy, because the first 2 would not screen me early on for indicators of preeclampsia. And I knew it, because I'm a mom, right? I know I'm gonna have preeclampsia again. And guess what? I do. But I end up finding a gynecologist that believes in me, that listens to me, that admits me when he has a hunch that something's gonna cook. I end up in the ICU with ketoacidosis, and a baby born healthy, but at the 34 weeks. But I end up with someone who saves my life and my baby's life, because he listened to me. Needless to say, this was all done while we had a crisis, while access to care was very expensive. I had to juggle 2 jobs just to be able to fund my diabetes and my pregnancy. But I came home with a child this time. And it's a very heavy story, you know. I don't like telling it too much, because it really bumps people. It's not a very happy story. But when I remember my daughter, it really fills me up with love, because somehow I'm here because of that experience. And somehow I'm able to help women and people with diabetes because of that experience. And I just hope this story really gives you more insight into looking at the patient as a person. And we might not have went to med school. We don't have all the technical know-how, but we know when something is not right. And we shouldn't have to advocate this much to be heard. So this is my story. This is how it looks like to to manage diabetes in crisis, to manage diabetes not in crisis, but in a healthcare system that doesn't work. And I will keep using this story to push forward because women with diabetes and people with diabetes deserve to live an honorable life, to be respected, to be heard. And I really hope one day we can move forward to the global targets. We move forward to a place where you really don't have to do this much effort to afford insulin, to afford proper health care, and to just live like a normal human being. Thank you.
Thank you, Serene. Thank you for your courage and generosity in sharing that with us. Many things jumped out, but the one about your gynecologist who listened to you. So I think we've all listened to you today, and I hope we continue to do that in informing this. Doris, we're happy to hear from you what WHO has been working on regarding guidelines and how that might help moving forward. Thanks.
Thanks, and thanks for having me, and thanks for my co-panelists and for these powerful stories. I'd like to say that I think, Serene, your story is really powerful. I came to WHO 15 years ago to let women who are dying from postpartum hemorrhage that somebody is listening. And I would like to say that I think we are listening on the needs of diabetes, and here we'll talk about diabetes in a very particular setting, the humanitarian setting, because it's critical. What we know from WHO and all the estimates that we do is that when we look at maternal mortality, morbidity, it's concentrated in women who are living in low and middle income countries. A girl who's growing up in a humanitarian setting has a 10 times higher risk of eventually dying from a maternal cause in her lifetime. I mean, that's staggering in and of itself. And then if you take that and you understand that these cases of morbidity and mortality are happening in humanitarian settings, plus in the same intersection, low and middle income countries, and then you put on top of this that people are dying prematurely from non-communicable diseases in the same community. You don't have to be a mathematician to do the math, but the intersection between a woman having a non-communicable disease, like diabetes, and pregnancy is just about inevitable. It's going to happen. And so WHO has always been working on reducing maternal mortality. We started this in earnest when we started looking at the MDGs, and now in the SDGs, Sustainable Development Goals, of how we can reduce maternal mortality. We also look at maternal health as a barometer for how a health system is doing. If you can do well by the moms and the women who will become moms, you can typically do well by your population. And where you can't, it's exactly the opposite, right? So what we started to work on, of course, we have guidelines on things like preventing and treating postpartum hemorrhage. That's the #1 killer of women in their reproductive age. The #2 is preeclampsia, as we've been talking about. And then the third largest group of causes is what we call indirect causes of maternal death. That's really all your non-communicable diseases lumped together, okay? Of which diabetes is one big one. And starting in 2020, we started looking at a program of how could we actually develop guidance that is globally relevant. So I think, one of the things that we noticed is that, yes, there are guidelines that exist for the management of diabetes. They tend to be developed in high or middle income countries. And where you have guidelines existing in low and middle income countries, they tend to have been adapted from that high income country guideline into another setting. So not really that sort of global level of thinking. So just to maybe move things quickly, the intersection of pregnancy and women having NCDs means that we need to look at this across that life course. So we have started in the maternal section, working very closely with our colleagues in the non-communicable disease section, to start from where a healthcare provider has to do something. That is, she has shown up pregnant, and guess what? She has diabetes, and you can't say go somewhere else because you're supposed to be taking care of her. So we start there, and the goal is that over the next couple of years, we will actually get guidelines through from she's pregnant She's had her baby. She goes out of the maternity care system back into the regular health system. She may or may not ever come back into that maternity care system, but that transition needs to be seamless. So we need to do this circle. It's not going to be easy. I can tell you there are a lot of people who are detracting from this, but I can also say to any member state or any country or any minister of health who says, I want to do more for maternal health, the first thing I'm going to say is, what have you done for postpartum hemorrhage? What have you done for preeclampsia? And what have you done about non-communicable diseases? They usually can tell me something about postpartum hemorrhage. They usually can tell me something about preeclampsia. What they can't tell me anything about is non-communicable diseases. And you know why? It's because nobody can own it. It's not easy to solve this problem. So if you really want to do something about it, you're going to have to invest in this. And it's not an investment of 1 year. It's probably an investment of 10 years. I'm going to be retired by then, but you know what? I'm going to still keep going on it because I've got to pass the baton on this to somebody else who's going to come in my stead, right? So there's no easy fix here. And so one of the things that I think we need to think about, particular to the humanitarian setting, is how do we put NCD care into that package of sexual reproductive health care, because that's one thing that's very common and very often spoken about. What's also spoken about is NCD care in the humanitarian settings. Why can we not put this together? We're sitting here in the same room. I think we should be able to. And I think there is will to do that. We are publishing in November, knock on wood, for World Diabetes Days, the first global guideline by WHO on the management of pregnancy for women who have diabetes. That's type 1, type 2, or gestational diabetes, as Chloe described. It's agnostic because she's come in, you've got to take care of her. So we anticipate having published 27 recommendations across some core practices like diet, physical activity, education, how to provide care, how to monitor glucose, what kind of treatments, insulin, metformin, other agents, and whether other additional monitoring like fetal monitoring or retinopathy screening or renal screening, how to implement these things. I can't tell you any more than that because we're under embargo, but that's a sneak peek. Look for this on November 14th. I think the biggest thing that I want to let you as a group know is that when we develop global guidelines, yes, we look at the effectiveness of whatever intervention we're talking about, if it's a medicine, if it's how you give care, et cetera. But also critical to how the guideline panel looks at how they're going to make that recommendation is how the qualitative experience has been described. So were these interventions acceptable? Were they feasible? Then, are they cost effective? What are the resource implications? And ultimately, the guideline panel is looking at sort of what we call the balance of effects, And so they will make a recommendation. So when you see this guideline, there'll be one line, one sentence that says, you should or you should not do this. And there'll be 20 bullet points after that to give you context of how you can anticipate actually implementing this recommendation. Now, in the setting that we're talking about here, we probably need even more specific notes on implementation and how to do this best. And so I've actually been talking to our human rights advisor and some other folks who have been looking at adaptations for sexual reproductive health care in humanitarian settings. And I think the next step that I would love to see us be able to do is to have a specialized way of delivering care for NCDs, diabetes in a humanitarian setting, and what does that really mean for care of diabetes across the board. And the next sneak peek is that in 2026, look for WHO guidelines on the screening of diabetes in pregnancy. That will be a big one. Thank you.
Thank you very much, Doris. So I think we've had a great three panelists kind of explaining to us a bit overall the situation, the needs, some of what's been worked on. Let's hear about the experience on the ground. So Reham is going to share with us the experience of UNRWA. Thank you.
Thanks a lot, Philippa, and thanks for inviting us here today. It's a real pleasure to be with you all here today and to share a real-life experience from UNRWA's implementing diabetes and pregnancy programs in a humanitarian setting, in an emergency crisis setting. A setting which is usually marked by the limitation of resources and as well marked with the challenges in access to care and sometimes where you need to context-specific, context-sensitive adaptations for the guidelines or for the approaches. Usually those kind of contexts are hitting the most vulnerable people, one of which is the pregnant mother with diabetes. So UNRWA tried earlier to integrate the maternal health services, sexual reproductive health, and the NCD services with the pre-existing primary healthcare services using adapting the family health team approach and the life cycle approach, where this is a person-centered approach, providing a comprehensive care through a multidisciplinary team at the level of the health center, or the whole family is visiting the health center and receiving care as a comprehensive package of care. This type of approach will decrease or avoid having like parallel systems providing different services, and this will by time prove the cost effectiveness and cost efficiency of those services provided, along with building the resilience of this healthcare system, especially for systems that is working in a continuous different types of crisis. Sometimes we're encountering like economical crisis with limiting the ability for the patients to access to care. Sometimes it's a political crisis, sometimes it's war, sometimes it's a nutritional crisis, and different types of crises are affecting the ability to provide those services and make it more important to have a resilient healthcare system. The services themselves are provided under standards of care that is adapting international adapted guidelines. We are standardizing those services across the 5 fields of operation by adapting technical instructions and the capacity building of the staff on the ground as continuously underbuilt to ensure that the standards of care are applied across the 5 fields of operation similarly. But unfortunately, when the crisis hits and we start encountering limitation to access to care, limitation to early diagnosis, limitation to early screening, etc., and we are also encountering the interruption of supply, all the well-working key performance indicator for the program itself becomes challenged. In general, UNRWA is having like at least 5 visits for a pregnant mother during her pregnancy time. 75% of our registered pregnant mothers coming to our health facilities during their first trimester. We are having a good system of screening and diagnosing. We have a good system of risk assessment for the mothers. Under the life cycle approach, we have the preconception care, where the mothers are also categorized based on their risk status, and the care provided is accordingly categorized according to the level of the criticality of the risk of that matter. But again, unfortunately, when the crisis starts, it becomes more and more important to keep integrating those maternal services through the pre-existing systems, where the point of care for the mothers at a different time when she's coming to the health center, it's becoming like a precious visit to make sure that we provide the full package of care to the mother at that time. The issue of the access to treatment as well is encountered during a crisis time. Access to the treatment, availability of the treatment options, storage capacities, syringes and other kind of things are also encountered during the crisis. And one of the most important, and I would like here to confirm what Sirine mentioned, like the capacity of the women themselves. Because in the middle of a crisis, the woman may find herself, should make a decision for her own health. This decision should be informed one. So, and she's not able to make this decision. So access to alternative methods of care like the telemedicine, the teleconsultation, investing more in educating the patients, like providing like what we are witnessing now, waiting time, awareness sessions, developing educational material during the crisis, how to deal with the, for example, treating diabetes in the current food insecurity situation in Gaza, for example. UNRWA is doing a lot of in this regard, aiming to bring to the pregnant mothers the way they can make the informed decision for the benefit of their health themselves. The experience of as well of having an open communication channel with the pregnant mothers is useful. So the telemedicine and having access from mothers to consult with a doctor once she's unable to reach a facility, health center facility, shelter, etc., is making like a big difference in the raising awareness of the mothers and making them able to make informed decision. One also important point, even during a crisis, is the data and the early registration and the collection of data to like inform the policy making and inform the strategies that need to be followed during the crisis. Collecting data in the middle of crisis is not an easy job anyway. UNRWA was having a robust e-health system that is every single patient or client visiting UNRWA health facilities having a comprehensive medical file, electronic. This robust e-health system is supporting us to analyze real-time data and moving onward with and like data-driven decisions. But once the e-health is lost due to connection, due to other issues, which is also encountered during crisis, we continuously, we directly shift to minimal data package to be collected for pregnancy. We still continue to encourage the early registration and all the strategies that ensure that mothers get early access to care. Challenges to provide NCD and integrated this NCD with the maternal health services, with the primary healthcare services are faced on daily basis on the ground. Trying to overcome these challenges as well cannot be done by one organization or one healthcare system. Collaborating with other organizations and the mapping of the services and keep contacting with the pregnant mothers and patients and educating them can make a positive difference and improve the health outcome for pregnant mothers and others.
Thank you, Reham. Thank you, hello. Thank you, Reham, and I'll certainly come back to you on some of those lessons that you've had from that experience. And last to Nelly, to share with us the MSF experience, what we've tried to do, what we failed to do, and how we might improve that.
Okay, thank you very much. No, this is not the right...
Keep going, it should go to yours afterwards. If you just click it in. Voilà.
Okay, this is mine. So thank you, everybody, for the invitation. I'm going to present you the experience and the challenges that we have to include the diabetes in pregnancy into routine care. So I'm going to present you a few slides on the sexual and reproductive health portfolio, a little bit of data, history, and background information before jumping into some field experience, and the last slide on the perspectives. So I want to highlight the SRH portfolio because it's mainly done by midwife, and when we talk about integration, it's asking something more to the midwife. So actually last year we did integrate SRH consultation in more than 237 MSF projects. Just to show you that in terms of portfolio, it's nearly 50% of what we do is related to the antenatal consultation, following by the contraceptive care and deliveries, including the C-section, which is of importance if you want to include diabetic patients, postnatal care, and then we do a lot related to safe abortion care and post-abortion care to reduce the maternal mortality. So this slide is just to show you the continued growth and the MSF sustained commitment to offer care for the women in the world. A little bit of data. This is to show you that we do nearly 3 million consultations related to women's health every year at the MSF movement level, and it's to show you that in terms of antenatal, it's more than 1 million consultations. I think it's quite key because when you talk about integration, it's a huge opportunity, but it's a huge challenge because we are doing a lot everywhere. If we jump into the data related to the debate last year, it's more than 200,000 consultations that were done. What is interesting here is to show that despite the three main countries where we are doing that, which is Myanmar, Bangladesh, and Syria, you see on the left side the variety of the context where we are able to integrate the diabetic care. And also on the right, what is interesting is the fact that we doubled the number of consultations in the past 4 years, going with the evolution of the prevalence of the disease. A little bit of history and background of the diabetic in pregnancy. I think, from my knowledge, we started to be interested with the crisis in Middle East and the Syrian refugees that came into Lebanon. In MSF, we are investing in from 2012 in this context, and this is where, and I think this is why it's important, it started from the ground. It's people from the field that were asking us to do something about that. So at the beginning, it's a little bit chaotic, I would say. So we have sort of ad hoc protocol and guideline, and then they try to do the best with what they have. But I think this is very MSF style. No? So we start from the ground, we learn from what is feasible to do, and then from that we start to have an harmonization of the guideline between the different sections. So now we have an intersection guideline in MSF to address that. From that, then we develop some training modules to make sure that we can have more and more people on board to do this care. So today we are working on this integration into care. I'm going to show you some few experiences, just because we don't have so much, honestly, to share today. And even if there is always an ambition to have a full scale-up, we are very far away from that now. In terms of training module, and I was very happy to hear all the experts, because we are not very far away from what should be explained. So we are explaining the NCD portfolio, because it's already a huge one, but then we are focusing especially on the preeclampsia and eclampsia and the diabetes during the pregnancy, starting with the risk factor, the impact. We are showing some tools, some algorithm, screening and treatment option, the importance of the follow-up of the glycemia and all the education that have to be done for the woman, but also the focus of the fetus with the potential to do the ultrasound monitoring, the labor monitoring. What does that mean in terms of the planification of the delivery, access to C-section, and then follow-up of the newborn. In addition to that, we also try to focus on the nutritional lifestyle. So the first experience that we had was in Lebanon more than 10 years ago. That was a very interesting context, because for the first time we had a huge willingness to address the NCD, and there were already a huge willingness to address the SRH. So we had those kind of two teams in the same compound that makes the things able to have this connection between those two teams in terms of referral and control referral. At least this is what we had in mind. This is what few people had in the country. I hope that this was done, but I have no data to show to you. We realize that, and I don't care so much. I mean, I really care by the fact that there were a willingness, there was something that was done, but I have nothing to share from that. Then, and this is where I'm very proud to bring you today, is in Kiribati. So I never heard about that before in my life. Just started in 2023. We decided in MSF to focus on this island in the middle of nowhere in the Pacific. You have the big island with the MSF base, and you have many small islands, and one of them is Abayang, where we started to do a work focusing. So it's a pilot where we focus on the community-based approach to address specifically the high blood pressure and the diabetes during the pregnancy. We are very proud of that, full of challenges. And this year, we are even going to start to do the monitoring and the follow-up of the women that we send to the hospital level to see the outcomes of all the treatment that we try to do. The other thing that I wanted to share with you in this slide is the fact that for the first time, we put a set of indicators, which is very nice to see, starting with the number of pregnant women that can and that do attend their supposed to be 8 antenatal visits from the WHO recommendation, but we'll go back to that. But monitoring on the number of women with high blood pressure, the number of women with diabetes, and you see the indicator number 4. I was amazed to see that is specifically addressing the OGTT, so the screening at the 26 weeks of pregnancy. So we are very proud of that. Then there is other monitoring that we want to put in place, which is referral to the hospital and the outcome of that. There is another series of indicators at the end of the slide that is very interesting, because it's showing the follow-up of the qualitative aspect of it, which is, for example, the medication compliance or the defaulter rate. A little bit of results. So on the right side, you can see the settings in which we have to work. Very interesting. So there were a survey that was done in this island, focusing on 12 villages, where we were able to screen more than 50% of the women in childbearing age. So it's nearly 100 women. What did we saw? We saw that the prevalence of the known diabetes was nearly 8%, and I think it's not so far from what you did present from the Australia data, so it's not false information. Then there were two things in the analysis that was very interesting. The first one is to see that there were nearly 2% of the women who were screened that were not known with a history of existing diabetes, but with a potential undiagnosed diabetes. And the other interesting thing is the fact more than 60% of the women who were screened with a known history of diabetes probably have a poor or suboptimal control of their diabetes. So I think this survey was really interesting for us to push to really work more on that. Yesterday, we received the last report from the field, so it's very fresh news that I'm going to share with you. It's full of challenges, as you can see. So we have only 17% of the women that complete the recommended number of ANC visits. Here, we are focusing on only 4, because in MSF, we say that if already you attend to 4, it's not so bad. But if you go to 8, I think it's nearly 0%. So what does it mean? It means that there is a huge focus that needs to be done in terms of strategy to have an increase of the antenatal attendance. So we want to work with the community, the women's group, especially the women-led initiative, focus on the education, mobilization. And what we saw from some focus group discussions that were done by the team is the fact that many pregnant women today still do not understand really the importance to go for the antenatal consultation. The other big result that I was looking at yesterday is related to the OGDT as such. So first of all, they were full of challenges coming with the supply and the stock and the training. So this is already addressed. First line is done. Then what we can see is we still need to do much more in terms of health promotion session, especially to encourage the women to come for the antenatal visit with the specific needs to address the OGTT period of time. And also we need to do a lot more in terms of training, because we did the monitoring of the improvement of performance that was okay 1 month after, but then decline again 2 months after. So it's really showing that it's not only one training, but it's an ongoing training if you really want the team to be to cope with what they have to do. Other challenges, so one is related to the shortage of midwife. They close the midwifery school, so now it's nurses that have to work as midwives to cover the gaps, but for sure it's not exactly the same knowledge. The other thing, and I think you highlighted previously, is the huge challenge related to the poor record keeping, no data collection tool. Even if you have the patient file, it's not very well filled. And then even if they do the OGTT administration, it's not recorded. And if it is recorded, they don't say if it is positive or negative. So yeah, this is where we are today. Perspective to finish with. So the good news, as we say internally, is we are going to add the screening of the pre-existing diabetes and also the GDM in the next version of the MSF obstetrical guideline, which is an intersection guideline, and that means that everybody can have access freely on internet. So this is a very good news. Then we are going to continue the dissemination of the algorithm, the protocol, the guideline, continue to have more training, and push for, hopefully, an integration into routine care soon. Thanks.
Thank you, Nelly. And since you have the microphone, I might start with a question for you. So thank you. I mean, you've outlined very well 2 examples where we've tried to integrate care for women with diabetes into our SRH care, but these were very specific examples, right, where we had a focus on either this topic or on NCDs plus on antenatal care. You also mentioned, that we're providing, millions of consultations for ANC, and that midwives are really providing quite a comprehensive package of care. So I just want some reflections on you on where this leaves us for considering a more routine integration of, screening, particularly for diabetes, and then eventually of, management of gestational diabetes and pregnancy.
Yeah, thanks a lot, Philippa. So a few things. So the needs are always here, and definitely in the high prevalence context, and we are working more and more in this kind of high prevalent context. Coming into the challenge, for me there is three. The first one is the competition of priorities. And if you see how we are struggling into the revision of the new guideline and try to make the ANC chapter digestible for the new midwife, it is challenging. For sure, our priority, for example, today, the triple elimination. So because we already integrated the syphilis and the HIV, now we want to move on with the integration of the Hep B. So voilà, you are going to enter into competition with this one. The second thing is about the knowledge gap. So despite the training, despite the information sharing and everything, we still have the midwife that have to deal with everything, and she's not a specialist. So second challenge. And the third one is related to the model of care. The thing that we saw, and especially from HIV experience, is you need to have a simplified model of care if you want this to be integrated easily. And I was very happy to hear all of you, but I think we are still a little bit far away from that when we are talking about a workforce that have very little knowledge on a lot of things that we are asking them to manage on a daily basis.
Thanks. So moving on from that, maybe Reham, we can try and learn a bit from the UNRWA experience, knowing that you have, implemented this care in more stable settings, but then of course experienced the acute disruption to care. What would be some of your key lessons for humanitarian organizations that are trying to implement more standardized and better quality care for women with diabetes and pregnancy?
Thanks, Philippa. Actually, it goes back to the same idea of the integration of the service within a full package of services. Like if you have a full package of services and you utilize every point of care or access to care for the mothers to the primary healthcare system, it will make it like working not only for the pregnant mothers, but also for other like preventive or early detection health priorities, like for example, the child and the child nutrition and the child development. So the integration with the pre-existing system within the setting of the humanitarian, it can make it like more sustainable, more resilient, and more cost-effective, and will avoid like those parallel systems that will usually not be sustainable. The other one is to have a high level of engagement with all the stakeholders that is providing diabetes and pregnancy within the same context, like to prioritize the supply, like to mapping of the services, like to share the stock levels and etc. And maybe one also important is the open communication and enhancing the health literacy and the health-seeking behaviors of pregnant mothers, that when you start educating the mothers that those kind of information are useful for you, if you are facing this, you should do this. This make it more important for them to seek more and more information. And honestly, Philippa, one of the main assets of UNRWA is the staff of UNRWA, frontline staff who are working under severely challenging conditions, and they didn't stop working for one day. I met midwives that are personally displaced in the West Bank. I met displaced doctors. We all know the conditions of our colleagues in Gaza who are working under displacement, malnutrition, and all those challenging situations. But nevertheless, they never stopped providing services to their communities, even for one day. So investing in the capacity of the frontline staff and the well-being of the frontline staff, and because they will be the one who are implementing the programs on the ground, and they are very close to the needs of the pregnant women with diabetes and other patients we are dealing with, is also key to have a program succeed and to have this program implemented well.
Thank you, Reham. And yeah, absolutely, the frontline staff, I think for all of us, we see how critically important and amazing they are. But I want to pick up on Reham's point about the education of women and their need also to be able to make decisions and in challenging circumstances. And Serene, you mentioned your need to Google and to find information and the pushback that you had on that. So just any reflections from your side on how people providing care in humanitarian settings can better help to empower women in this sense?
So, like, when I think of that question, I think as women in the Middle East, it's kind of a taboo to visit a gynecologist before you're married, which is a big thing. So when are we really educating little girls about their bodies? Not just that, not just pregnancy, also menstruation and diabetes. There's so little studies on that, but like, I'm a woman, I know my insulin needs vary along the month. And so it's like, what age is the starting age where we educate women in general? And then when is the starting age when we educate women with diabetes about their needs in general? And what are global guidelines and frameworks that force the governments to do that? In Lebanon, healthcare was 90% privatized, meaning people used to go to private clinics and private hospitals, paying out of pocket. So really didn't rely a lot on primary healthcare clinics. So I think we need to reshift on who delivers this kind of education. At what age do we start educating girls with diabetes? And the more we equip them with knowledge and the community, because I believe in the power of support groups, the better they can handle any situation that they might face in the future, whether it's humanitarian crisis, war. I mean, I've lived through like 5 wars now along my life. So like, the more you're equipped, the stronger you are to react and to know how to handle these situations. And like, I'm just posing questions because I don't have the answers. I think we're here all together to figure out what the answers are. So maybe that helps.
Thank you, Serene. So yeah, I mean, and certainly we, MSF saw during the conflict in Lebanon the critical importance of the peer groups. Then your point on kind of education, I guess to use emergency lingo, the preparedness for pregnancy and seeing how as a community we can help to prepare women ahead of time. And that's one thing I've often reflected on as well, is that we talk about, identification and management of women who have during the pregnancy, but actually looking into management of women living with diabetes and preparing them for a pregnancy is something that's under-addressed, I think, in many of our settings. So Chloe, I was a little bit anxious after your presentation, seeing how challenging it is as well in high resource settings and how there are many things sort of not yet clear as well in terms of the, the best package of care to put in place and so on. But I guess with your experience and your expertise, knowing that there is a lot of debate and a lot of unknown factors, but also hearing huge challenges we face on the ground and the complexity and the competing priorities, what would you see as the top priorities if a humanitarian organization had to make some tough choices for implementation of care for diabetes and pregnancy?
Yeah, I think I'm looking forward to the WHO guidelines. I can't wait to see them. And I will say, having recently sat on a guideline development panel for many years, I'm sure that 26 recommendations took a very long time. But insulin, that feels like the floor. Having access to insulin in large quantities that is not costly feels like a sort of basic have to have. I think how you monitor, I'll set people with pre-existing diabetes into one bucket, and I think for those folks, how you monitor them, that'd be something that's really, you'd have to contextualize. So do people have access to a device that would allow them to wear a continuous glucose monitor? And if so, it's actually probably more cost effective. We don't have that cost effectiveness data in humanitarian settings, but my guess is that a CGM might actually give more bang for the buck. But I think because the monitoring for people with type 1 diabetes, and I didn't say this, but for people with type 1 diabetes during pregnancy, they're very susceptible to going into DKA actually. Euglycemic DKA is a well-known phenomenon in pregnancy, so your blood sugar does not have to be profoundly uncontrolled. It can just be you have a UTI, and that can flip people into DKA if they are limiting access and monitoring, if they don't have the ability to monitor what they're doing. I think for gestational diabetes, GDM is a resource choice. As I demonstrated, like, depending on what criteria you use, you can diagnose 4 or 5% of your population with GDM or 30% of your population with GDM. In a setting like the US, we still haven't agreed upon should we be diagnosing 5 to 10% or 30 to 40%, because that has really profound resource implications. Is it true that keeping people within a normal blood sugar range helps their pregnancy outcomes? 100%. the most impactful thing for people with gestational diabetes is actually probably lifelong chronic disease management. And so I think that the one thing for people with gestational diabetes, once it's identified, if you were going to choose to identify it, would be to find a way to refer them into some sort of diabetes prevention program.
Super, thank you so much. And yes, we are very much looking forward to the WHO guidelines. But Doris, I guess in going through the process of the literature review and understanding the evidence, there were probably some gaps, and particularly related to humanitarian settings. So it'd be great to hear from you, what would you see as the priorities moving forward if we needed to research, document, try specific aspects related to management of diabetes and pregnancy?
All of it? No, very honestly, at the end of the guideline, you will see that there were a list of research priorities that the guideline development group identified. And I read through them again today, and they're in my bag. Nobody's trying to steal that from me. But I think there were like 30 questions, and they span from very simple, basic epi data. You'll see you probably remember from Chloe's early slides, just where we have data. So there's huge swaths of the world that we actually don't have population level data on diabetes, and we certainly don't have population level data on diabetes and pregnancy. This confounds and complicates our ability to advocate for the need for this space. The 1 in 6 or 1 in 5, it's probably an underestimate, but you need to try to find this. So I would say, when we're having a big discussion now when we're looking at the screening guidelines. The evidence base is actually really poor. This is no surprise to any of you, but I've got an evidence base that looks like this, and I have the usual requirements of WHO that say it should be like this. And so the job that myself and Bianca, who's in the audience, who's my NCD counterpart, is to see how we can bring the reality together while we push to have more evidence. And I would say, I'm going to give you an example from a completely different context. One of the guidelines that I led was on the clinical management of female genital mutilation. Okay? Nobody had had this before. WHO and UNFPA partnered to do this. And everybody said, why would you do this? There's no evidence. And my answer was, there's no evidence because nobody's published on it, because nobody's asked for this evidence. We published this guideline, I want to say in 2019. This guideline has now been updated because guess what? People published evidence. It is something. It's better than nothing. So if there's any plea that I can give, it's yes, we're going to start from small studies. They're going to get aggregated. We need to look at how outcomes are defined so that we can put them together into meaningful meta-analyses. There's a lot of methodological innovations that we can use. But at the end of the day, WHO wants to know, what is the evidence? What can we hang our hat on to say it works? And if it works, is it acceptable? Will people use it? We could have the best drug or the best intervention in the whole wide world. It's horrible. Nobody wants it. Nobody wants to do anything with it. Don't use it. Don't recommend it. It's not going to go anywhere. So what can we recommend that will have has sustainability, that has a way forward that can be usable? And I think that's where we're trying to frame this out. So I would be very curious to see how the research prioritization I know that you're going to be working on tomorrow, and we could look at how these overlap, because we'll have a prioritization exercise again afterwards when we want to update our guidelines. And that's where we'll say, these are the most important questions, because all the different stakeholders are saying, this is the most important thing. And this is where, as WHO and as HRP, the Human Reproduction Program, we say to the big funders and the member states in the world, if you want to do something, put your money here. All of you, put your money and do something here. One great study done well is better than 50 little tiny studies that have lots of methodological problems. So we need to think big, and that's where I think we can actually do a little something. Thank you.
Thank you, Doris, and thank you for also bringing it back to the importance of it being relevant to the people living through it. That's great. Let's get some reflections and some questions from the audience. Suhair.
Okay, thank you very much, everybody. Thank you, Serene. Thank you, Chloe. Thank you, Nelly, Riham, and Doris. You've really addressed the issue completely from A to Z. It's a comment rather than, a question. Based on my experience, I worked as a field family health officer for quite some time in Gaza in 2017. And one of my areas of interest was diabetes in pregnancy. And now I'm the Chief Disease Prevention Control in UNOWA, and it is my area of expertise. So Serene highlighted the importance of two things, which is the preconception care for the women with diabetes and the antenatal care. Because, in our culture, or a recent culture, people think that managing diabetes or managing pregnancy in general with its complication is mainly the role of the specialist, which is not the case. The primary health care is really the cornerstone of providing such care for everybody, including pregnant ladies. So this is one area. And the other point I just wanted to comment or add to what Chloe has said regarding the priorities or the things that we need to have is really we need to have the diagnostic tools during emergencies and crises. We've had this experience in Gaza because we didn't have oral glucose tolerance test to enable us to diagnose. So we had to develop a criteria for diagnosing the gestational diabetes based on the fasting plasma glucose adopted from WHO. And even this one was really very challenging because of the overall situation, and the non-availability of food in Gaza over the past 2 years actually has made this very challenging. The other thing which is important to the issue of managing, the condition of those patients during pregnancy, in pregnancy and during crisis in particular, during emergencies, is the nutritional support, is the nutritional advice to the women. Those malnourished women, they are more prone to have diabetes because, everybody knows that undernutrition and overnutrition are also a risk factor for developing diabetes. So imagine the situation in areas, or not only in Gaza, in different areas, but we are giving Gaza as an example, as a live example for this one. So this is an important area as well. Dr. Reham has mentioned the many issues related to this, but continuity of care and provision of treatment is the most important part of this. We need to have to find this. Standardization of the diagnosis. We have a very wide variation between the percentages of I would say the diagnosed gestational diabetes 1 to 5, and in some areas less than 3, less than 5, less than 20, less than 30. We don't have a standardized percentage. We need to have a standardized percentage based on the studies and meta-analysis as the rest. Thank you.
Thank you, Zuhair. Definitely this challenge of diagnosis using the oral glucose tolerance test is one we faced as well, and so also very much looking forward to the WHO guidelines. It's not pragmatic in every setting, and so we definitely need alternatives, but yes, certainly a lack of evidence around that, so it will be great to see what comes from it. And the nutritional support is a huge challenge, in humanitarian settings, not just for pregnancy, but for people with diabetes in general, so we'll be addressing that tomorrow in the session tomorrow. There was another question over here. Thank you.
Thank you very much. My name is Ahmed. I'm from Palestine also. I'm the chairperson of Diabetes Palestine Association. Actually, I'm one of the fans of working in the community and adopting a community approach for the management of diabetes as a model for other NCDs. In this context, I want just to ask the panel about the role of community health workers and the traditional birth attendants in all this process, and what we are doing to support them, since we know that even if we Google it for the published data, we will see that a huge number of women, they do not do the delivery under the medical conditions. I'm not blaming them, and of course we need to live with this reality. My second question is that how you see the role of all of us, especially the WHO and the national health systems, in being prepared for disasters and do our job in the disaster management and disaster risk management beforehand, since we know that the second disaster is very close. Thank you.
Thank you. For the first question, I'll ask Nelly and Reham to comment. Nelly, MSF has certainly done quite some work with traditional birth attendants.
I can say a word for the second question as well. So for the traditional birth attendant, I think this is very interesting because there were some policies from WHO around them, and then it was shifting, but the reality didn't shift. So the reality is most of the women, they are still delivering at home with TBAs. So the position of MSF related to that is we work with them, but we are not going to give them the option to do home deliveries. So the way we work with them is to train them, to sensitize them on the fact that you may have women dying even if they didn't have any risk factors. So it's not about doing a triage of the one that you can do at home and the one that you can refer to the hospital, but it's really to work with them to make them understanding that they need to take care of the woman, but then ask the woman to come to the healthcare structure to deliver. Then what can be included, because maybe your question is around that, what can be included with the TBAs related to diabetes? I think first thing is to make them aware about already what we discussed today, about the different type of diabetic, the one that you can develop during the pregnancy that can stay after. I'm sure that most of them, they have no knowledge about that. And we have to start from that because they are not stupid one. So if you give them information, they will be the first one that can refer to the other one. The question about the preparedness for disaster is a key question in MSF. My personal opinion is we need to be much more faster than what we are today, and we need to anticipate. So it's not about being faster when something happens, it's how we can better anticipate what's happened, and what is happening in front of us is huge.
Thank you, Nelly. Reham.
Thank you, Nelly, for commenting. I would add more comments on the first question. I would agree that the reality didn't change. Maybe because you're coming from Palestine, this is reflecting the limited to access to hospital care and hospital deliveries. For example, our data is showing that still more than 90% of the deliveries are taking place in hospitals, but the shift was from the facility of the hospital itself to field hospital, for example, but still all or almost all deliveries are attended by skilled personnel. Maybe the one I would highlight from real life example again is to build the capacity of the not community workers, but have like multiple delivery centers to cope with the movement restrictions, for example, in the West Bank, and to cope with the inability to reach the hospital facility for a delivery. I would also highlight here the high rates of the cesarean sections that have been a problem across, for example, for UNRWA and other, like the host governments we're working with. The reality of having high rates of cesarean section make it more limited to have those kind of community workers having deliveries at the level of the community. So still the safe deliveries in a hospital setting is needed and promoted for and supported, and data from the fields are supporting having those kind of deliveries and the safe deliveries.
Great, thank you so much. So we're almost at time, so we're going to wrap it up. I want to thank the panel very much. I think it's been a very interesting and diverse conversation. I think we've heard about We've heard about, the high prevalence of gestational diabetes. 1 in 5 is quite a lot, plus women with pre-existing diabetes. We've heard about how challenging it is to manage, even in high-resource settings, but some encouraging examples of where that's been done. We've heard about the importance of kind of coordinating the care and centralizing the care, the importance of the kind of family medicine and approach, and the key role of midwives also to coordinate care. And then the need for more research and more work on this, so I hope we can all work on that going forward. I'd like to bring us back to the reality and the lived experience and give the last word to Serene.
So thank you. It's interesting because I always said we should have a seat at the table, not just a seat, but actually have a say. And Doris is over there drafting all the frameworks and stuff, and I'm the lived experience. We're on the same table, so it's kind of interesting. But one thing from a lived experience perspective is I would like to see more people with diabetes living life successfully. I was at a conference in Geneva 3 months ago, and it was the first time I see an 80-year-old with type 1. And that gave me hope, that I can actually, I can see it. I can see how it looks like to have a full life with diabetes. And I would like other women to see how it looks like to have a full life with diabetes and motherhood, and not carry the weight of complications and what that would look like during pregnancy or after delivery or when we're old. I think we all carry that burden. If there's women here in the room with diabetes, they probably carry that burden too. So let's see how we can continue to share space on this table and see how we can get policy to actually serve people in a sense that it makes their lives actually livable. And thank you.